Okay, good evening, everybody. Thank you. I'd like to thank the organizing committee for giving me the opportunity to present the Saudi TAVI guidelines. So the aim of this document was to standardize the TAVI practices in different parts of Saudi Arabian centers through reasonable guidelines based on the evaluation and summarization of the best available evidence. These guidelines were done under the umbrella of the National Heart Center, with the participation of different societies involved in cardiac management, including the Saudi Heart Association, the Saudi Arabian Cardiac Intervention Society, the Saudi Society for Cardiac Surgeons, and the Saudi Cardiac Imaging Group. The guidelines were written by an expert from different fields in cardiac sciences, from different parts of Saudi Arabia and different sectors in the different health sectors. So a number of relevant clinical questions were proposed by the guidelines committee. The evidence was thoroughly reviewed to answer these questions. And then the literature searches were done, including randomized controlled trials, registries, systematic reviews, non-randomized comparative and descriptive studies, cohort studies, and case series. A series of meetings were conducted to review the available evidence and formulate recommendations for appropriate clinical practice. The review committee based their recommendations on the reviewed and analyzed evidence, and the class and level of recommendations were discussed until a consensus was reached by the panel. The initial draft of the recommendations were prepared, then reviewed again by all members of the review committee. The approved draft was sent to 3 external independent reviewers for further review and feedback. As you know, we base our recommendation on the different classes based on the effectiveness of treatment and how strongly it was recommended in the literature. And the level of evidence was the routine level of evidence A when the data was derived from multiple randomized clinical trials or meta-analyses. Level of evidence B was driven from a single randomized trial or non-randomized studies. And level of evidence C was when consensus opinion or case reports or clinical evidence was lacking. So here are our recommendations. So the first question we asked was the indication of TAVI in prohibitive and high-risk patients. And as you guys know from the different studies that were done and the clinical trials, that we gave it level of evidence, the class of recommendations were 1 and level of evidence A for both prohibitive and high-risk patients for TAVI. Then we went for the TAVI for severe symptomatic NAS in patients with moderate risk. And we divided that by age. If the patient is above 75, we gave TAVI a class 1 recommendation level of evidence A. And if the patient was between 65 and 75, we gave it class 2A level of evidence C. The same thing was for low-risk patients with severe symptomatic AS. We gave TAVI class 1 recommendation if the patient age was above 75 years old. We could not make any recommendation for a patient younger than 75 because there is no evidence for that at the time being. When we looked at the age separately as a factor to decide the indications for TAVI, we divided patients into patients who are younger than 65. So those patients younger than 65, they should get a surgical aortic valve replacement. Patients who are above 75, they should get TAVI. And patients in between should be based on the recommendations of the heart committee and the risk factors of the patient. Then we looked at asymptomatic patients with aortic stenosis. There is a clear evidence for SAVR in asymptomatic patients going for TAVI, for surgery, but we could not get any evidence to recommend TAVI for patients who are asymptomatic. And we did not want to extrapolate from the surgical literature. In patients with bicuspid valve, we divided them into patients who have aortopathy and their anatomy is not suitable for TAVI. Those patients should go for surgery as a class 1 recommendation. If the patient does not have aortopathy and the anatomy is suitable for TAVI, then we give it a class 2A level of evidence B. Reintervention, if the reason for reintervention was valve failure, then we gave TAVI a class 2A recommendation level of evidence B. Patients with LV systolic dysfunction, both patients who have LV systolic dysfunction can get TAVI or SAVR as a class 1 recommendation. However, if the patient have severe low gradient, low flow aortic stenosis, we give TAVI a class 2A. But if the patient have paradoxical low flow, low gradient, then he should not have either SAVR or TAVR, and medical therapy should be the standard of care as a class 2A. If the patient have a concomitant coronary artery disease, then either TAVI and PCI or SAVR and CABG should be done with a class 2A recommendation. And if we went into the direction of TAVI and PCI, then PCI should be done after the TAVI and considered as a stage procedure, except in patients with left main coronary disease. Then we went to patients with concomitant mitral valve disease, and we divided them into patients with mitral regurg and patients with mitral stenosis. And in patients with mitral regurg, we divided them into primary MR and secondary MR. So if the patient had a primary MR, then the patient should be surgical, unless the heart team committee decided that this patient is too high risk for surgical intervention, or the patient is inoperable. Then TAVI will become, now the class 1 recommendation here was given to the heart team decision, not for the TAVI. And for patients with secondary severe MR and severe AS, then it is very important to decide if those patients have the factors that will increase the likelihood that the MR will decrease after the TAVI. If that's the case, then this patient should go for TAVI as a class 1 recommendation. Now, if there's the likelihood of mitral regurg, the secondary mitral regurg, that it will not go away, then this patient should be surgical. And if the patient is inoperable, then TAVI is still a class 2A indication according to the available evidence. Patients with severe mitral stenosis, if balloon valvoplasty is feasible, then TAVI becomes a class 1 recommendation level of evidence B. And the patient, if the balloon valvoplasty is not an option and the patient is high risk for surgery, then the benefit of TAVI is questionable, then we give it a class 2B recommendation. So we have to be careful in patients with mitral stenosis who are not amenable to balloon valvoplasty and they are not candidates for surgery. Patients with peripheral vascular disease, the alternative access selection should be based on the heart team discussion. So what is the first option? Is it alternative access or is it facilitated TAVI? Facilitated vascular access using intravascular lithotripsy or angioplasty is given class 2A recommendation level of evidence C. And the choice of alternative access, including transcarotid, transcaval, transsubclavian, and transaxillary, were all given class 2A recommendation. Transaortic and transapical, unfortunately, the evidence is not in favor of doing this intervention, so it was given a class 2B recommendation. Patients on chronic renal failure, they are divided into patients who are not in dialysis, but they are end stage, and patients who already went on dialysis. And we know that the risk of dialysis patient in surgery is very high. So if the patient is end stage renal impairment without dialysis, then we give both TAVI and SAVR class 1 recommendation level of evidence B. If the patient is on dialysis, then TAVI becomes class 1 recommendation and surgery becomes class 2A recommendation, given the high risk of surgery in those patients. In infective endocarditis, we were very cautious. In only patients who had treated endocarditis with uncomplicated vegetations, maybe TAVI can be attempted in those patients as a class 2B. And heart team discussion is recommended to establish the optimal management for all cases of infective endocarditis. However, if the patient have complicated endocarditis or active infection or large vegetation or complicated vegetation, they should not go for TAVI. How about patients with severe aortic stenosis and non-cardiac surgery? Those patients should be stratified according to their risk. High-risk patients, they can get either TAVI or SAVR as a class 2A recommendation. However, if the patient is going for low or intermediate risk procedure, then he should not have either TAVI or SAVR. And the heart team discussion is recommended for those patients going for other procedures with severe AS. The role of CT scan in those patients is divided into either to use the CT scan as an alternative for angiography, or to use the CT scan for the different features of the root that will recommend those patients for TAVI. So using the CT scan for calcium scoring and the deployment angles for fluoroscopy is a class 1 indication, but using it as an alternative to coronary angiography is a class 2A indication. We could not make any recommendation regarding which type of valve is better, whether balloon expandable or self-expandable valves in TAVI. And for cerebral protection devices, we made it as a class 2A recommendations in patients with high risk for stroke, including those patients with renal failure, previous stroke, or significant calcification. Conscious sedation is given a class 1 recommendation in those patients. The presence of heart block, it depends on patients going for TAVI. There's two types of doing the pacemaker, either at therapeutic or prophylactic. So those patients who develop high degree AV block that persists 24 to 48 hours, they should get a permanent pacemaker as a class 1 recommendation. And is also patients with new onset alternating bundle branch block. Prophylactic use was ranging between class 2A and class 2B recommendation in those patients. Dual antiplatelet therapy is not recommended, only single antiplatelet therapy in those patients is a class 1 recommendation. And Plavix seems to take a priority over aspirin. And those patients they should not get dual antiplatelet unless there is another indication for dual antiplatelet, like an associated coronary disease. Anticoagulation is not used specifically for TAVI. It is used in those patients who have other indication for anticoagulation. And those patients have to be followed first time and after 3 months and then yearly after as a class 1 recommendation. Echo should be used in those patients to evaluate any suspected paravalvular leak post-TAVI. And if that's the case, then that should be confirmed by CMR. So in summary, these guidelines are derived from the critical evaluation of the best available evidence up to date. The current body of literature is based on the current and previously used devices. Some new studies are ongoing and some current and newly emerging technologies. Thank you.